Nashville, Tennessee. I am in Nashville. Anyone in Nashville? Anyone from St. Louis? New York suburbs, Georgia. We love it. All right. UK. Anybody else from overseas? We love that. What time is it in Manchester? Kansas City. I'll take Kansas City on the Missouri side. I'll take that, Clarissa. Joburg. Okay. Joburg is far. Now Joburg is far. 6 p.m. in Manchester. Okay, that's not bad timing. San Diego in the building. All right, that's amazing. All right, team, I'm going to go ahead and get started while folks are tuning in. I'm really excited to be here today. Again, I'm Morgan DeBon. I'm the CEO and founder of Afrotech and Blavity. Blavity has been around for over 12 years. I can't believe it. We have been in business for what feels like forever, but our mission at our company is to cultivate communities, networks, and information that furthers advances this community that we're serving, the Black community, the multicultural community, the community of people who are oftentimes overlooked and underserved. And so when I think about the responsibility of care and our topic of today's conversation, which is care reimagined and how new technology can create and invite us all to think about new care models, I'm really excited about the possibilities that we can create together. I want to give you a brief history on how we got here, and then I'll pass it over to my team to talk through the next steps. But Afrotech started a few years after Blavity, and Afrotech was created to bring together technologists to reimagine what technology could do, how we could be building responsible tools and products to advance our access to information, our access to tools, everything. We work with great companies like Intuit, Microsoft, Meta, Goldman Sachs, many companies that are huge institutions in our everyday lives. And we work with them behind the scenes with their employees, with their executive leadership, and with the prospective talent to make sure that their companies are diverse, inclusive in the products that they're creating, and to help reach all of you out with their products and services. So a few years ago, we decided to build HealthStack. I am a child of a doctor, Dr. Michael DeBon, here in Nashville, Tennessee. He's a hematologist oncologist and has a specialty in children with sickle cell disease. And because of how I grew up learning more than anyone ever want to know about sickle cell disease, listening to him talk in the car for his NIH grants that he was going after with his team and his clinical trials all over the world, and having the luck of being able to travel with him to these different sites. I've been to Nigeria, to Ghana, to London, to Paris, in partnership with my father, understanding the work that he's doing. And so I was able at a young age to have an appreciation for the innovation that can happen when people who are advocates for our communities are equipped with the right resources and technology to get things done. I'm incredibly hopeful about the future of healthcare. And I'm incredibly hopeful that if we come together, HealthStack can be a platform that can help accelerate each and every one of your careers of what we think health and care can look like. So today I'm excited to introduce some of the leaders that we'll be having throughout today's conversation. These are people who are at the forefront of AI, of digital health, of healthcare policy, and who are driving meaningful change across each one of those industries. So we'll have Dr. Jayne Morgan, Dr. Amit Phull, and who else? Dr. Monica, Chief Medical Officer at Covered California. And I believe that's our next panel team. Keep me honest here. But I'm excited for them to walk through this conversation. If this is your first HealthStack event with us, let me just tell you a few things. We have a healthcare conference, a health tech conference happening during Afrotech. So you can join us in person. We'll have 2 days of programming, excellent opportunities for networking, lots of conversations for advancement, including CME credits. If you need that for your work and staying up to date, being there, you can get your CME credits for different sessions. This is in November, November 2nd through 4th, I believe, or 3rd through 5th. The team will have it on the slides later, but in Houston during Afrotech Conference. So you can get your ticket at afrotechconference.com or HealthStack Med. But we have these virtual summits all over throughout the year. Now that you're on our email list, you'll get access to this. But our goal is to be of service to you. So feel free to give us feedback. Please take the survey afterwards because it's really helpful for us to understand how we can continue to serve you. And I'm excited for today's conversation. With that, team, I'm going to pass it over to you. Also, make sure you engage in the chat. We love a live chat at AfriTech, okay? And HealthStack. So don't be shy. All right, they're probably moving people over. For those who are just joining, make sure you tell us where you're tuning in from in the chat. And you can follow HealthStack on LinkedIn for most of our information. I'll drop that link now.
Hello, thank you, Morgan.
You're welcome. Hey, Aria. There you go.
Good to see you. Thank you, everyone, for joining us. I am really excited about this session, and I have someone special to introduce. Dr. Jayne Morgan is a board certified cardiologist and vice president of medical affairs at Hello Heart, where she leads cardiovascular strategy focused on prevention, population health, and improving outcomes, particularly for women. With extensive experience in clinical cardiology and cardiovascular research, Dr. Morgan is widely recognized for reframing menopause as a pivotal and underappreciated cardiovascular inflection point, and for advancing prevention at a time when heart disease remains the leading cause of death in women. Her work spans clinical care, research, digital health, and public education, allowing her to translate evidence based cardiology into actionable guidance at scale. Dr. Morgan has published across cardiology and COVID research and is a strong advocate for health equity, particularly increasing the participation of women and underrepresented populations in clinical trials. In parallel with her clinical and research work, she is a frequent on air medical expert for CNN and the creator of an award winning educational series, The Stairwell Chronicles, helping bridge the gap between medical science and public understanding. She serves as an adjunct associate professor of medicine at Morehouse School of Medicine and is recognized nationally as a leading voice in cardiovascular prevention, women's health, and menopause. You all, please join me in welcoming Dr. Jayne Morgan. Hello, how are you?
Hi, Aria. It's a pleasure to be here.
Thank you so much for being here. I saw your bio and I said, I have to say every word of this. You are an
I was just
incredible
thinking it's time to
physician.
update that and brevity is key, but I appreciate it.
I completely understand that, but you have extensive work, and honestly, it's all worth saying. So, as you said, brevity is key. So, we will jump right in with our first question.
Sure.
Most people outside of the industry have never heard of medical affairs, yet it is
Mhm.
becoming a make or break for digital health. So, in plain terms, what is medical affairs, and what does your team actually do at Hello Heart?
So when we look at medical affairs, we really oversee quite a few functions in a supportive role. And I think as as we continue to advance, medical affairs really will take on more of a leadership role, really
Mhm.
defining the trajectory. But currently, we support everything. We support product development. So product moves forward with medical affairs providing input into it. We develop research to make certain that our outcomes are peer reviewed and we can justify any of the data that we are discussing. We make certain that we are able to translate the information, provide the information not only to peers, to other physicians, but also to clients and to patients. You have to be able to speak at every single level. And we also have some crossover into marketing and supporting the types of marketing information that goes out to make certain that it's accurate and it reflects exactly what we're doing. And so medical affairs is quite broad. It has a lot to do with the relationship of the company with external clients, but also internally it has a lot to do with making certain that you are maintaining the rigidity, the control, the scientific integrity, and the standards. So it is a cross-functional cross-functional really across really the organization. So incredibly important. You know, my thought about Med Affairs is that at some point it will morph as we continue to see AI grow as well into a division that actually is leading and setting the trajectory and the strategy for organizations because it's really critical and essential.
Yeah, absolutely. That actually leads me to my next question in it being critical and kind of laying the land of the relationship between the organization and patients and clinicians alike. Trust is the theme of this conversation, and it sounds
Sure.
like it's a bit of a the theme of medical affairs as well. But
Mhm.
it's a hard thing to measure. So inside Hello Heart, excuse me, what signals tell you that you're actually earning the trust of the clinicians and patients?
I think one of the things that we have to always focus on when we are building models and building systems, and certainly we are an AI forward company, is who built it, right?
Yeah.
Who built it? Who trained it? Who validated it? Who tested it? That's all medical affairs. And I think it's
Mhm.
really important to understand and to recognize the importance of having different lenses in the rooms and to make certain that the data that is being built makes sense for all populations. And if it doesn't, speak specifically to what that population is. I spent a lot of time in the area of women's health. I'm a strong advocate for health equity. And so I knock on a lot of doors. And I'll be honest with you, sometimes those doors don't open, but I knock on them because my thought is that I should be in the room because I can provide not only my medical background, but I can provide a perspective, an experience, a lens on a product that's being developed such that you don't develop it in a vacuum. And then I see it way downstream and I think, I don't know if this is even relevant to women, or I'm not sure if this is relevant to the Black population, or here's how this population is going to perceive this because of the way you've named it, et
Mm.
cetera. And I think it's important to make certain that all of those perspectives are in rooms. As I said, I do knock on doors. I ask to be admitted. I push for research. Not always successful. I'll be honest with you, but I try to raise it to the level of consideration. When Dr. Morgan's coming, she's going to ask again. She's going to ask again. She's
Yes.
going to ask again. Um, and at some point the doors, can open and maybe they don't open for me, they open for someone later. But the fact of the matter is when we are training models, you have to have a perspective because these models will go out throughout the entire global society. And so you
Mhm.
cannot have an organization that's building, training, validating, and testing, and it's not representative of the world because you're going to miss something. So it's a mistake to have all the right degrees in the room, but you don't
Yes.
have all the right perspectives in the room.
Absolutely. That is a great point of who is building it, who are they building it for? Are they attuned with the people that need it? Do they know what they need? And then speaking about trust, what are the early signs that you're losing trust? I know that you spoke about knocking down doors, and they
Mhm.
know that when Dr. Morgan is coming, she's asking the questions, and if it's no, she's going to ask the question again. But how do other clinicians know, or people in medical affairs, how do they know when they're losing trust?
It's one of the differentiators between AI and
Hmm.
humans. And it's one of the reasons why it's going to be difficult, at least currently, for AIs to replace humans because
Yes.
AI is not very good at judgment. It's not good at uncertainty. It's not
Hmm.
very good at ethics. It's not super great at complex decision or emotional conversations or reading the room.
Yes.
Those are human factors, and that's where you build the trust. So AI doesn't replace physicians and other clinicians. AI really gives us superpowers, right?
Hmm.
It gives us the ability to be more focused, but also to pick up on those things like your wife averts her eyes when I ask you that question, or
Mm.
the subtle human cues that you pick up on, or that you seem to be tapping your foot as we're talking. So that may generate a follow-up question if something else is happening. Those are all things that AI can. AI is super great. AI can give us superpowers, but it's unable to replace that human perception of being there, especially seeing the person, hearing, feeling, and then understanding what's not being said. AI is
Mm.
great with what's being said once you give it the information. Humans are a lot better at what's not being said. And a
Hmm.
lot of times that's where the information
Absolutely.
is really hiding. So AI gives us our superpowers.
I love that. And you've spoken about many things that you've done, and your career has taken you from developing the Mitra clip at Abbott to
Mhm.
leading Piedmont Healthcare's COVID task force, and now you're shaping clinical strategy at Hello Heart.
Right.
So, what pulled you into the digital health space after decades of being in device and healthcare systems, and what kind of surprised you about the transition?
Yeah, so I had been working, as an adjunct, so it's sort of outside of
Hmm.
my day job in sort of the whole burgeoning tech space in Atlanta for years. I was the president of Southeast Life Sciences. I was one of the people really joining two organizations together to get a big tech presence there. We were building venture capital. I ran pitch rounds at my hospital, making certain we could identify patents and intellectual property. So I was sort of always in this area. It wasn't my day job, but it was a
Hmm.
big part of my after day job. And those were the things that were interesting to me. So it's not so unusual that I transitioned over into AI and digital care full time, especially as I became increasingly interested and focused and advocating for women's health. And especially when we talk about perimenopause and menopause and just the lack of everything. I won't even go through the list, just the lack of everything where that resides. I really believe that it's going to be menopause that's going to be the defining use case for AI in healthcare.
Mm-hmm.
Menopause will be the defining use case, and either companies will understand it or they won't understand it. It's a decades long transition, dynamic symptoms, changing cardiovascular risk. There are really few conditions that illustrate that type of value of longitudinal, personalized, AI enabled care as clearly as menopause. And the reason it will be a test case is because women's health for really all of eternity has been reduced to just reproduction. It's as if we have
Yes.
no other organs. But
Hmm.
menopause and perimenopause cross every single organ system. So this will truly be an opportunity and a test case because women are hungry for information. We don't have the
Yes.
research, we don't have the data, we don't have the information. Doctors aren't trained. The gap is so big, 12 trucks could drive through it. But that also means that there's opportunity there because this is where AI can step in and begin to generate the data that we need to begin to give advice that we need. And women are more likely to step into it because all the doors have been closed everywhere else.
Mhm.
And menopause is, we spend more than a third of our lives in menopause when you think about it that way. And there's no reason to be in poor health. So I really do think that it will be one of the defining use cases for AI just because the need is there. And so the adoption is like slurping on a straw, like, yes, yes, yes. I just want to, how fast can I slurp this?
Yeah.
And so it will be interesting to see.
And I appreciate your work in this area as a young woman because I've even seen that younger women want more information on
Sure.
perimenopausal menopause. It's something that people don't talk to us about.
That's
They
right.
talk to us about our menstrual cycles when we're little girls going into
Mhm.
adolescence, but then they just drop us off and never pick us back up.
Right.
Nobody ever
That's
talks to us about
right.
perimenopause until we're in the woes of
That's right.
perimenopause or menopause.
And then,
So
and the
I,
Black community is even kind of more entrenched in that. And that's why I think it's important to always have a lens because if you're building a platform, you're building AI, build it for everyone. Don't assume that your experience is the same as someone else's experience.
yes.
Invite that someone else into the room and just determine if the experience is the same. As it turns out, Black women have longer periods of menopause. We actually enter
Mhm.
menopause earlier. Our symptoms can be more severe. There may be a direct correlation to advancing vascular age, advancing cardiovascular disease, which is one of the reasons that I'm there. So it's important to understand. And then within our culture, just as you have rightly identified, nobody talks about it.
Mm-mm.
You never hear anything again. Now, that's partly, the culture, but it's also partly the way our health system and our society is structured. Women um, are relegated to sort of a suffer and suck it up and power through role. And that's
Yeah.
even more amplified in the Black community with Black
Hmm.
women. And so we will hardly ever complain about anything because we're there to take care of everyone else. And
Right.
what does that look like? And how do you get Black women on a platform when they don't see that as their job
Mm.
to take care of menopause and perimenopause? So, you know, that's a different perspective from other cultures, and that requires another layer of trust with a group that already has distrust. Actually,
Mm.
Black people trust AI more than we trust our physicians when we look at it. But the because we our thought is, well, AI can't see us. AI is not judging me. AI
Mm.
doesn't know I'm Black. So I get to ask a question and don't have to worry that they are, discriminating against me or including implicit bias. Unless I tell AI I'm Black, AI
For
doesn't know it.
sure. For
So,
sure. And Dr. Morgan, you have built that trust with the public, whether it be with your appearances on CNN and of
mhm.
course the Stairwell Chronicles. In that communicating the trust or getting people to see the importance of digital health, what have you learned about communicating medicine to patients directly that digital health companies keep getting wrong in their products or in their communication?
Yeah, I think, always making it simple. And I think actually digital health companies are doing a great job with making it simple. But here's the part where a lot of companies don't do, and I think Hello Heart actually does a good job at doing this. That's in you give the data, and now
Hmm.
what do you do with it? So now there's time, now we need to connect the dots and create a pathway of understanding and then an actionable item. So that takes the person or the patient or the member or the individual or whoever you want to call them, from point A all the way to point B. We don't just
Hmm.
give you data as a wearable and then, your heart rate's up or, you skip to B. What does that mean? Now
Hmm.
we say, oh, here's what this means. Or did you take your medications or what is happening? And then here are the next steps you should do. What is your action item for this such that you understand it? Not only do you understand it, then if it happens again, you already have a level of comfort with what's going on and what you need to do, or even how your behavior may have been impacting that. And so I think AI is getting some things wrong and right as we move forward in this new frontier, but
Hmm.
it's getting a lot of things right. There are just still some human things that simply can't be replaced currently.
Absolutely. And in that event of clinicians kind of explaining the benefits of digital health to their clients, clinicians are trained to be measured, right? Maybe not skeptical, but measured. And many digital health products have earned a bit of skepticism or at least trepidation. So when you're building an evidence base for a product like Hello Heart, what exactly moves a skeptical cardiologist from, okay, that's an interesting app, to I
Mhm.
would recommend this to my patients?
Yeah, here's what moves a skeptical cardiologist. Number one, you're not adding workload to me.
Mm, hmm.
Number two, are you actually making it easier for me? Did you just take 1 minute out of my day? 1 minute is
Hmm.
powerful. Did you just
Yes.
take 2 minutes? Did this patient now, with the tools that you've provided, give me enough information that I can interpret immediately to actually not only give better care, but to be able to make that decision more quickly, which leaves me then more time to talk with that patient or more time to determine some of those other, as I said, subtle, soft symptoms that AI is unable to pick up on. So, number
Hmm.
one, are you making it harder for me? Epic
Right.
is hard. Cerna is hard. These are the health system, electronic health record. They get all of these pop-ups, all of these notifications. People honestly oftentimes just disable them because there's so much coming at you. It takes away from your focus on the patient. They're trying to be helpful. So we've kind of gone overboard. And so AI has to also be cognizant of doctors are going to push back strongly if it gives them just one more thing to do. They will engage strongly if it actually is going to make their lives easier. It's going to take
Mhm.
something off of their plate and
Right.
there's a better outcome. That's really the bottom line, the workflow. And right
Mhm.
now, physicians and other types of clinicians are inundated, overwhelmed, overburdened, um, burned out on all of the responsibilities that they have in the digital world, a lot of which don't have a lot to do with taking care of the patient. A lot of it
Mm.
is documentation and these,
Yeah.
these types of things. Um, and so, that's the reality of where we are. So the company that can make it easy
Hmm.
and decrease the time for the physician is the company that wins.
And that makes sense because if taking care of patients is at the crux of the job, we need time to take care of the patient
Mhm.
and not to document and note. I understand that
And
completely.
look at yet another, now that the patient is, giving us another document to look at and another,
Hmm.
and we need to, oftentimes the physician comes in with an agenda, right? He's reviewed the patient's records. There are things that she or he want to discuss, but the patient also comes in with an agenda. There are things that he or she want to discuss, and a lot of times those
Hmm.
things are different, but you still have the same finite amount of time. So
Yeah.
how can you make that physician's time or other clinicians who are seeing them
Hmm.
imperative? I say physician because I'm a physician, so I'm talking from
Hmm.
that perspective. And that's
Right.
a great example of it's why you need different perspectives in the room. I am speaking from the perspective of a physician.
Right.
That may not be the perspective of a nurse, but I think I can speak, pretty clearly for all clinicians. For all
Absolutely. And
clinicians.
I can attest, I am one of those patients. I'm coming in with a notepad on
Right.
my phone. I have a whole lot of questions.
Right. And yet your
Um,
doctor may be worried. I don't know your medical history, but your doctor may be worried about something else. Like, oh,
mhm.
her blood pressure's up. I need to make sure I check that. I want to make sure I grab these labs. And you come in talking about an eye disorder and and it's just like, oh my gosh, how am I going to pull all this together?
Yes.
Right.
Yes, exactly. Dr. Morgan, I have one more question for you. For the founders and builders watching who don't yet have a medical affairs function yet, when is the right time to build one and what should they look for in their first clinical hire?
Yeah, I think the right time to build your medical affairs division is probably from the beginning, even if you have simply a single hire. And you need someone who really has a broad background. So I'll give you an example of my background. Not only am I a physician and I've done a lot of patient-facing work, seeing patients, managing patients, also have a background in research, in industry, right? Leading big clinical trials, leading research, and doing medical affairs there. I have a background in business development. What does it look like when other companies have products that you want to acquire that align with the goals of your company? Though that is a broad background. How do you have you worked in a large healthcare system? Um, and you have that system experience in healthcare systems, the systemness. Do you
Yes.
understand that after being a part of it? And do you have, experience in tech and startup? These are all just examples, but med affairs, people who are working in med affairs, the broader background is actually more helpful than a very narrowly focused background. That person who has crossed over into many areas of medicine and sees it from a number of different lenses, and who has actually functioned in a number of different roles in all geared towards improving patient care. That's the kind of person you're looking for really in medical affairs.
Understood. Well, thank you so much, Dr. Jayne
Yeah,
Morgan. You
sure.
have truly blessed me today with all of your gems. So thank you so much. And I will pass it back to my team.
It's a
Thank you
pleasure.
all so much.
All right. What a fantastic conversation. Yes, really an immense amount of gems dropped. Thank you so much, Dr. Morgan. We are so excited to move into our next conversation. Before I get started, my name is Simone. Welcome again to this virtual summit. We're going to keep the conversation going. I'm Simone Tyler. I'm the Senior Vice President of AfroTech and HealthStack, and we are incredibly excited to have our guest today. But before I introduce him, I want to get a sense of who is in our chat, who's in the room today. We haven't actually pinpointed. Are we physicians? Are there nurses in the room? Do we have healthcare leaders? Drop in the chat your titles, where you're coming in from, and what organizations that you're with, just so we can kind of get a sense of who we are talking to. UX managers, so we've got some tech folks in here, physicians. All right, it is a mix. Fantastic. Healthcare consulting, RNs. Okay. And then we've got folks that cross over all industries. All right, fantastic. That is really helpful. Thank you, guys. So I have Dr. Amit Phull with me today. He is the Chief Clinical Experience Officer at Doximity. I'm sure that most of you all know about Doximity because they have literally led the charge as it pertains to integrating into healthcare systems, particularly around AI. It is a network that reaches, I believe, more than 80% of US physicians, which is huge. He's a board certified emergency medicine physician and still practices, I hear. We're excited to talk about really the impact of Doximity on the industry, but also make sure that physicians and the folks in the room understand how we are talking about AI, how they can better trust some of these systems. And also, it looks like we also have some engineers here. So I might add some questions that are a bit more leaning towards that group of folks. So, Dr. Amit, welcome to the conversation.
Thank you for having me. It's an honor to be here. I'm super excited.
Fantastic. So I want to talk about adoption first. What we all have seen is that across multiple industries, AI adoption has varied depending on the industry, depending on the people. There's big headlines. You've been talking quite a bit about this. I'm really curious, where is the gap between what headlines are saying about telehealth and AI and what you are actually seeing and how doctors are actually utilizing Doximity?
Yeah, that's a great question because honestly, in today's information environment, it's often easy to forget what you just said, that what people are screaming from the rooftops is very different than usually how things work when you actually show up at the doctor's office. So
Mm-hmm.
when we see that gap, the best I would characterize it would be a lot of the noise around healthcare I would say is it's more investor focused. So the announcements are around money raise, the announcements are around these very large volume projections or the future and how all of these problems might be solved or medical superintelligence might be generated. Prior speaker pointed to some of the gaps that exist between kind of the dream and the upside and
Mm-hmm.
what is like actually happening today, like simple practical things, right? I'm an emergency medicine physician. If you imagine that I walk into any ER anywhere and do work and all of the even medical pieces of technology are working, you're wrong, right? Like folks who've
Mm-hmm.
seen the pit or themselves ever been in an emergency department know that it's complicated when you actually have to deal with the real life implications. So we've observed a pretty significant gap between kind of the hype, if you will, and the healthcare reality. And it
Yeah.
came up in the prior conversation. Often it's the unsexy things that move the needle on the clinical side. So while thinking about an AI robot or chatbot being able to synthesize all of the information in the world and providing you some perfect answer to your medical complaint is something we should all continue to aspire in the direction of. What we hear from users and see in their usage is simple things like saving them a couple minutes on their documentation. That's
Mm-hmm.
the kind of thing that adds up. When we first surveyed our membership base before even building out our AI toolkit, we had several hundred respondents estimate that they could save with AI, well designed and well positioned AI, about 12 to 13 hours a week. Now, that is
Mhm.
an insane amount of time to save anyone, right? Like, usually when we're
Yeah,
giving this kind of talk in front of a group of people, I ask them to raise their hands and some volunteer, like, what would you do with 12 or 13 hours of extra
yeah.
time? You might take a nap, you might sleep a little bit more, watch a movie, do kind of human things. As a physician, even if you are ruthlessly efficient, I do clinical work at places where we have 8-hour shifts, and you might see anywhere from 25 to 35 patients during those shifts. I could see 12 hours more worth of patients if I just had
Mhm.
tools that are well defined and honestly focused on the more practical things. So it's early innings and it's easy to forget that. What we try and do is focus on what our users are telling us and showing us in their usage to lean in and really unlock a couple minutes here, a couple minutes there, because that's how you ultimately get folks to really value what you built for them. But more
Yeah,
importantly, have more time to be more present with their patients, potentially see additional patients, or frankly, just be more human, right? Every doctor could use a nap too. So if we can save them those little bits of time, there's a little bit of a gap between, hey, I raised $800 million last week and my technology actually doing anything for clinicians.
yeah, yeah. Thanks for sharing that. And I guess to that point, most of this is through AI scribes, right? So these are people that are, or agents that are supporting at bedside. How are you seeing that patients are reacting to that? So, for example, I recently took my toddler to his pediatrician, and she then asked for my approval ultimately to use an AI tool to take notes. What are you seeing between the gap between, the physician and the patient and bedside feeling comfortable with AI being part of those types of conversations?
It's been pleasantly surprising. I will say, for context for everyone, looking backwards in time, for the better part of a decade, if not longer, AI from a clinician's perspective, there's been a lot of fear mongering associated with it,
Hmm.
right? You can go back several years and look up articles about radiologists being replaced by AI and
Hmm.
everything being recorded and clinicians becoming these kind of Amazon factory workers who are being monitored for every minute of their activity. And I don't want to paint an idealistic picture where none of those risks exist at all. We have to be mindful of deploying the technology responsibly. But we get
Hmm.
a lot of feedback from clinicians that it's actually that interaction, like you just described, Simone, where your pediatrician leans in, it's like, hey, I'm using an AI tool. Are you okay with that? It paradoxically like establishes this bond between the two humans where they share in that
Hmm.
decision. And by virtue of taking some of the lift off of the human clinician, it permits them to be more involved. Like we've gotten a lot of positive feedback actually within pediatrics because pediatricians are experts at using little tools as toys to distract your kid. They bring the
Hmm.
otoscope up and they pretend it's a
Yeah,
puppet, like that kind of thing. So the AI is like fascinating to a kid and it's
yeah,
distracting in a positive way. So I would say my perspective on it is I'm cautiously optimistic that patients and providers alike embracing this technology, it can actually restore some of the humanity to medicine, right? Prior
fascinating.
speaker had mentioned so much of the work is just administrative, kind of random minutia that detracts from
Hmm.
your ability to actually be a doctor. I get a lot of positive feedback. All of the Doximity product feedback, me and my team are on kind of the business end of that fire hose, and we will get all of the inbound, both negative and positive. And the positive bits are usually things like, I actually got to spend an extra 10 minutes with my patient and counsel them through this critical thing because I didn't have to jet and go type 3 notes, so that
Yeah.
kind of thing is actually pretty significantly positive in terms of the early signal that we're seeing.
Fascinating. And then how do you manage that against accuracy? Obviously, the previous conversation they talked about trust, but I also, as most of us probably are AI users now, whether we wanted to be or not, right? Where do we manage things like accuracy in those 12 to 15 hours that are saved? What are the checks and balances to make sure that the tools are actually, in fact, working for us and that there aren't missteps in information?
Uh, Nothing from my seat could be more important right now where we sit in terms of not missing the boat on this one. If we
Mhm.
mess this up, in healthcare, we have this habit of responding very dramatically to negative things. And then
Yeah.
unfortunately, that response lingers and prevents us from really unlocking the upside. So when we survey our users, the vast majority of them, when asked about their primary concern about this technology, they respond that reliability and accuracy are top of mind.
Hmm.
And our approach, for what it's worth, is we can address that by being honest and being transparent, and arguably just as importantly, if not more importantly, being humble. This
Hmm.
technology has a ton of upside potential, but if we pretend like it's already perfect and somebody goes and takes output that's erroneous and does something wrong to somebody, and then, as you know, the
Yeah.
dominoes that that would unleash would be pretty significant. We just have to be careful. We have to be diligent, right? Internally at Doximity, we use a lot of catchphrases to try and motivate our teams, et cetera. And we're a Silicon Valley company, and the tech catchphrase, of course, has always been like move fast and break things.
Hmm.
That's not applicable in healthcare, right? On the other end, you have the Hippocratic Oath, which says first, do no harm. That means you kind of have to move so slowly that sometimes you miss the train when it comes to new technology. We've kind of put both of those together. We think we can do both. You can move fast and do no harm if you're honest, you're humble, and you're transparent about it. Anyone who's told you that they have already built medical superintelligence is lying to you.
Yeah.
It's just not real. So if we can expose that fact to clinicians, tell them, hey, we're going to develop and deploy this with you. We're going to leverage your expertise to make sure that we can continue to aspire towards that perfection while owning the fact that we're not there yet. That's the ticket. Listen, I
Yeah.
use a lot of tools, Doximity amongst them, in my clinical practice, but it's my clinical practice. It's my license. I have the liability, and we need to establish that trust with the clinician user first. And we think that's the only path, frankly, to actually being truly trustworthy when deployed at the point of care.
Yeah. Thank you. And you've been at Doximity for a while.
Yeah.
Certainly longer than most folks stay at an organization in Silicon Valley. Um,
Yeah.
so you've seen quite a bit. You've gone from early stage to taking the company to IPO. I am sure there are things and projects that you have launched at Doximity that have been rejected by physicians. Tell us a little bit about what that has looked like and sort of how you've managed continuing to build for the future while also testing new things.
Yeah, that's a great question. We had some friends over for a dinner party, and one of my friends who used to live in San Francisco with us mentioned that. It's like, oh, you've been there a lot. And they started kind of making boomer jokes on me. I'm not that old, but I have been at Doximity for a while.
Yeah.
What I think I've enjoyed most is that it's constantly evolving, right? So we take our process honestly, probably more seriously than even the output of that process. And that process entails interfacing with our users, being transparent about what we're trying to build, and most importantly, asking them what we should build. And what
Hmm.
I've certainly learned along the way, and we as an organization have learned along the way, is that often people think they want X, but then you build it for them and they're like, no, that doesn't really work the way that I thought it would. So there are multitudes of things that we have tried and failed at, or
Hmm.
tried and got it not quite right, and then kind of iterated on to really stick the landing. I'll give you two examples. Everyone thinks that they want like group chat for clinicians, but
Hmm.
when you build group chat for them, they don't use it, right? So we
They don't
have,
have time.
yeah, they often don't have time. They're
Yeah.
bouncing around. Don't get me wrong, we have point-to-point secure messaging that is quite powerful and growing in terms of its usage and its user base. But the idea that you have a bunch of clinicians just sitting around kind of like WhatsApping one another has not
Hmm.
really taken off, at least not at scale. Doximity Dialer, which is one of our more significant workflow successes, the initial feedback there was actually we just need a call spoofing app so that we can kind of make patient calls on the go. If we
Hmm.
had listened to clinicians and just stopped there, It would have been fine. It was a very successful call spoofing app when it was deployed, but it has come so much further than that because we continue to re-engage. We have the ability to reconvene our membership base, ask them again, not only, hey, what is it that you're bothered by most that we might be able to build some solutions for,
Mhm.
but reporting back, we just built that thing for you. Is it what you wanted? Can it be improved? I mean, Doximity Dialer went from being an audio only call spoofing app that at the end of 2019 was hosting about 25,000 audio calls every day. And we
Wow.
were quite happy about that. Then, of course, 2020 happened and things evolved and patients' needs and physicians' needs evolved. A lot of our user base came back and said, hey, Dialer's good, but it's not good enough. Can you maybe lean in and add video, add support for texting, add support for interfacing with AI, et cetera, et cetera? Those things were not on our roadmap.
Yeah.
But just being present and kind of listening to our users, we did a lot of those things. And in the first year, from not supporting kind of a full virtual visit, i.e., zero visits on Doximity, we went to 63 million visits in that first year alone. So, what we have learned, I think that's most significant, is that if you can just present yourself to people and say, this is what we're working on, tell us how to be better.
Hmm.
It goes a really long way. One, because they'll tell you, doctors will tell you if they ask, if you get
Yeah.
some time with them, they will tell you what bothers them. And then when you build it for them, it gives them a sense of kind of pride or ownership in the output that
Hmm.
gets them to lean in further. So that's been like a tremendous learning that I've certainly taken away from the million years that I've been here at Doximity.
Yeah. And to that point, I think, if they keep giving you the feedback, right? And adoption holds as you kind of currently see it, what does this actually look like in 5 years? We've got a lot of product people in here that I'm sure are always thinking about what the future of this work looks like. What does a perfect world look like in 5 years from now?
Man, a perfect world in medicine is so hard to describe. My joke, as I mentioned earlier, is that, hey, it would be great if this was Minority Report and we rolled in and there was a big screen and we can control everything. And then I think about
Hmm.
my reality where it's like, I can't even find an ophthalmoscope in my ED that works. And that's just
Mm.
literally because you just can't, right? So there's always going to be that tension between ideal and what is practically accomplishable. I
Yeah.
would say, though, from my personal vantage point, one of the things that I recall from my training, emergency medicine training, you often have to do oral boards. So you have to walk in, and instead of taking a test and selecting kind of answer choices and multiple choice questions, you're given a patient vignette, and there's a proctor kind of simulating a patient, and you have to ask questions. You have to elicit all of that information, literally down to things like what do I see? What do I smell? What can I
Mhm.
touch? What are the vital signs? The reason I bring that up is that there's something pure about that in terms of the intellectual and even human encounter that
Mhm.
practicing medicine usually entails. So, our hope is that we can have well designed enough tools that they sort of fade into the background.
Mm.
It's still going to be contingent, of course, upon technology working and frankly the power being on, right? And the internet working, et cetera. Like I've worked in EDs where there's epic downtime and all sorts of craziness can be unleashed. I think there was a Pit episode about exactly that, right? So you have to have all these default backup mechanisms. But perfect technology in the healthcare space is almost invisible.
Hmm.
It fills the need that the clinician has communicated to the team that designed it, but it serves as an extender of that clinician when they're in the room with the patient. So if I
Right.
can walk in almost regardless of what the scenario is, put my hands on my patient and examine them, interact with them in a way that elicits the information I need to advance kind of diagnostics and treatment. Ideally, all of the tools that we can develop around that clinician will make that faster, more reliable, and take away some of the burdensome elements that are downstream. So that's the dream. If in 5 years we can accomplish that, that's hard to say, but if you told me a year and a half ago we'd be doing half the stuff that we're doing right now, I would have reacted the same way. So timing of things is super difficult to
Yeah.
prognosticate these days, but we're well on our way. The rate of change is like nothing I've ever seen before. And the rate of embracing change, particularly if you can do it within the context of this kind of relationship where we're building together, it's been really, really powerful.
Fascinating. And then my last question, I'm just want to kind of dig back into this around the trust piece. As things start to grow, there becomes this it makes headlines, but I don't actually know if it's real inside of a doctor's office, which is that, potentially a doctor is now saying, I no longer need to use my own judgments. I can leverage what is being output here and help that make me allow that to make decisions on my behalf or for my patient. What would you say to that? And where is the balance between, the years of experience that a doctor already has versus leveraging AI tools and outputs to make decisions in the doctor's office?
That's a great question. I think the approach that I take personally, certainly, and then we take as an organization is understanding that there's a very significant difference between data that's very different than information, which is very different than knowledge, which is very
Hmm.
different than experience, which is very different than wisdom, which is very different than expertise.
Hmm.
All of those things are required to have judgment. So, how we speak about these technologies and how we build into those words is very, very important.
Yeah,
And assuming that information can hop over those like 8 gaps that I just mentioned and become judgment is a very, very dangerous assumption. And we think the best way to remind everyone of that is to employ clinicians in the development of this technology. Because anyone who has spent their entire life earning that judgment
hmm,
takes that judgment piece very, very seriously and is not about to just hand that over to a keyboard and a trackpad, right? So we have to be humble but own the fact that expertise exists and it is
yeah,
earned. And information can help an expert, it can augment their practice of medicine, but by no means is it intended to replace their judgment.
right.
So the more we can beat that drum, and frankly, the more you can ask everyone you ever talk to that question, so we can continue to beat that drum, I think is one of the most important things of where we sit today. Like right now, the technology part of it is, you could argue, if not already, but rapidly being commoditized.
Yeah,
The trust layer and how that feeds into workflow and how that ultimately uplevels our clinical judgment, that's where I think the actual game is today and where interesting things might happen in the very near future. But in order for clinicians to embrace this and really advance not only their own practice, but ultimately the whole point is improving patient outcomes, we have to be careful with our word choice and make sure that that narrative is persistent so everyone understands what it is that we're actually trying to do.
absolutely. Well, this has been an incredibly fruitful conversation. Thank you so much. I appreciate your time. I appreciate your expertise. We're really excited to see and continue to see the work that you all do. If there are any other questions, I'm sure the team will send them over. But thank you so
Okay.
much, Dr. Amit. We appreciate your time today. And I will hand it over to the next conversation. Thanks
Thank you
all.
for having us. Thanks, everybody.
Good day, everyone, and welcome. I'm Dr. Crystal Redmond. Thank you for joining us for today's fireside chat titled Redesigning Access, Chief Medical Officer on Closing the Gaps in Who Gets Care. Over the next 30 minutes, we'll explore how policy, technology, and health systems design shape access to care long before a patient ever enters a clinic, and what it will take to build a more equitable healthcare system. It is my pleasure to welcome Dr. S. Monica Soni, Chief Medical Officer of Covered California. Dr. Soni leads Covered California's Health Equity and Quality Transformation Division, supporting nearly 2 million Californians in their pursuit of health and wellness. She is a board-certified internist and associate professor at UCLA and Charles R. Drew University. A graduate of Harvard College and Harvard Medical School, she completed her residency at UCSF. In addition to her leadership in healthcare policy, Dr. Soni serves on the board of Mercy Housing California and previously served as a commissioner for the Los Angeles County Hospital and Healthcare Delivery Commission. Her career spans frontline clinical care, health equity, and state-level health policy, giving her a unique perspective on how policy decisions translate into real-world access to care. Dr. Soni, thank you so much for being here, and I'm looking forward to our conversation. How about we dive right in?
That sounds great. Thank you for having me and for facilitating this.
Absolutely. I'm excited. So the first question we have today is, Covered California has shaped access for millions of people before they ever choose a doctor. Walk us through a decision your team makes, a network requirement, a benefit standard, a funding formula that most people never realize impacts how they get care.
Yeah, I love this question. And maybe as a little bit of a precursor for folks that are not as familiar, Covered California is the state-based marketplace. So we are part of what came out of the Affordable Care Act, Obamacare. As you said, we support nearly 2 million folks right now. But over maybe about 5.5 million Californians have passed through our doors since we were first created. And we're not an insurance company, but we do have a lot of agency over what you just described, access. So I'll give maybe a couple examples of the way that we really think about primary care as being a critical backbone of the health and wellness we all want. I'll say primary care is the only part of the healthcare ecosystem that has been shown to improve outcomes and reduce costs when you get more of it. So more primary care, better outcomes. So the dollar there is very valuable. So to that end, we think about how do you make a benefit design that encourages people to get primary care? We reduce copays there. We exempt it from deductible. We have that be the most accessible part of the system. We also make sure that when folks sign up for health insurance, they're automatically assigned a primary care provider, even if it's a PPO plan. We believe that the first touch point should be a primary care access point. We also think about this from a health plan perspective. We want our health plans to be doing the good hard work and giving us value for our dollar. And so we have asked our health plans to actually think about continuity of care within primary care, so that you're not seeing one person this day, another person the next day, and not having someone who knows you and understands you and your priorities. And so I think we're the first purchaser, and we consider ourselves a purchaser of healthcare, to require our health plans to both track, monitor, and improve continuity of care in primary care. And then finally, I would say, healthcare in America is a business. And so, sometimes money talks, and our health plans do respond to financial incentives. And we do have big money on the line for our health plans to do preventive care. Colorectal cancer screening, making sure folks with chronic disease actually get that disease optimally managed. And that's another part of our tools and our toolkit to try to drive change. And that's all on the back end, right, before anybody actually engages in the system.
That's beautiful. And I think that gives our viewers a bit more insight on some of that back end, as you said, and behind the scenes that work. And then so externally facing, we're also navigating policy. So you've practiced in the Los Angeles County Safety Net and served on the county's Hospital and Healthcare Delivery Commission. And now you set policy at the state level. What do you believe the front line knows about access that the policy table usually misses? And what did you only learn once you got to that policy table?
Yeah, maybe I'll share a story. So I used to run all of specialty care for the Department of Healthcare Services, which is the second largest municipal health system in the US, second only to New York. And we had a lot of challenges getting people in to see specialists. And particularly, I'll use one specialty example, which was podiatry. We had a lot of people who had chronic diseases like diabetes, and they needed to see the podiatrist. And so this was like a system-wide effort. We're doing all sorts of, routing people here and there, and clinical algorithms and, infrastructure. And then I found out that there was like a secret podiatry clinic There was a set of podiatrists who were seeing patients, but they did not want to be part of the larger integration because they wanted autonomy and control over their own schedule. And this is one of the things I think gets missed at the policy space is so much of access work, so much of transformation and redesign is people and culture dependent. Is that specialist really willing and wanting to see a sicker patient? What happens when you double book or triple book? Are people willing to work through lunch if needed? Are the people on the ground actually community and person centered or not? I mean, these are things you really only know if you are there, embedded and enmeshed in the work. And so I think sometimes a policy can seem good, but then really fall apart when it starts to get implemented. And then on the converse side, like you said, on the policy piece, it is important that things are able to scale and be replicable. You don't want to be perpetuating inequities just because one part of the system knows how to implement and operationalize, and another part maybe doesn't have the skill, will, or resources. And so there's this tension between hyper-local regional knowledge, best practice, and the need to have it have full state impact. California is huge, from the rural north to, urban LA. What is a set of interventions that actually benefit all of those folks? So I think that's the part that often gets missed is we have to, yes, have a floor, and we have to raise the bar, and the rate of change is not always the same depending on what the circumstances are.
Yes, I love that you mentioned like going from this systems approach, primary care, talking us into policy, but then you also put a highlight on people and culture and how that leans into access, which is perfect because that's what we're going to be talking about next. So as viewers now know, you serve on the board of Mercy Housing California. How has affordable housing work informed how you think about health access? And where should health leaders be looking beyond their own industry?
I think health leaders should always be looking beyond their own industry. I'm grateful my husband works in real estate, private equity, and finance. And so we have very different day-to-day experiences. And so at the dinner table, when we're sharing, challenges, there's so much I learned from what, is going on in the private sector that has influenced me and my thoughts as a public servant. And it's the same thing. Me being on Mercy Housing Board, which is the largest provider of affordable housing, builder of affordable housing in the country, has taught me so much about community. So, in California, Mercy Housing California, there was both funding and desire to build permanent supportive housing, right? We have a real crisis of insufficient housing and the number of people who are dwelling on the streets. And so there was this movement for a while to have housing that was 100% permanent supportive. These are folks that had been chronically homeless or homeless for some set of time, all in one place. That turned out not to be the model. I mean, we have properties that are operating like that, but it's tough on the residents, it's tough on staff, and it's tough on buildings. The number of repairs that had to be done to the physical infrastructure because of the population that was served had not been accounted for in the economic model. And so to me, the takeaway there was that integration is better, that balance, a balanced portfolio is better. On the healthcare side, our Medicaid program is a racially segregated system. Yes, it's based on income. It tends to be in California, Black and brown. That is who is served by our Medicaid program. It's different providers, it's different funding, it's different oversight than what I get through my employer-based coverage, than what I deliver as the leader of Covered California, which is marketplace-based coverage. And so one of my takeaways, I think, in the long-range planning that we might do as policymakers is what does more integration actually look like that's not based on one demographic factor like income, and instead an intersectional view or a place-based view that's less siloed.
Now, you love it. I love it when I hear providers talk about community and all the other beautiful gems you're dropping around access, people, culture, integration, intersectionality, all of those beautiful things because there's intention behind it. And as we're having conversations about digital tools and technology, I think that balance exists, right? Where we balance community access and those voices and the realities of our system that we're navigating with these new tools. So that walks us nicely into our fourth question question, which is, where is technology genuinely improving access? And I think the term there is genuinely, genuinely improving access right now. And where do you have concerns about digital first tools?
If I'm not a Luddite, I'm an early adopter. I believe in the power of technology. I believe in technology as team, though, right? And so I guess this gets me back to both pieces of your question is we have seen a sort of incredible impact of things like home testing. I know the data best on colorectal cancer screening, but it's not necessarily super slick technology, but in terms of access, it's one thing to need to clear out 2 to 3 days to prep and do a colonoscopy in a highly impacted system with a specialty that's impacted. It's another thing, if it's appropriate for screening, and again, this is encourage people to know your risk factors, to get a kit mailed to your house. You can do it at your convenience, and then you can send it back. And then if you are, if your screening test is negative for colon cancer. And there's lots of data that does suggest that actually you can even enhance the impact of that pretty low tech, but thoughtful technology. And so I've seen our own data, I've seen our health plan data, I've seen national data that really shows things like that, meeting people where they are as simply as home testing. On the other hand, I think I have concerns about any digital tool that is a point solution. And what I mean by point solution is that it's solving a niche specific problem and it's not integrated into anything else. Because as we were just talking about, we're talking about our full human being experience. Everything is connected to everything else. Just focusing on one little tiny piece of my healthcare or health experience or health needs is not really the way to be doing the future orientation of care. And there are studies that show that discontinuous care, I go here for that, I go here for that, without coordination and true integration leads to higher costs, worse outcomes, and mortality. So that's where I don't want to see us go.
Thank you for that. And I am viewing the comments too as well, and we'll get to questions a bit later. I appreciate the centering on equity, and there seems to be conversation around justice. Like, how do we create justice-centered models that truly center the community, right? And even going beyond that to like cultural humility, cultural humility and how we can use these tools to balance out all of those beautiful things. And I think that nicely positions us into the next question. So as folks know now, you lead a division with equity in its names, health equity and quality transformation. A lot of organizations treat equity as a value statement, and I think that is a word right there. What does it take to run it as a measurable, accountable function? And how do you measure your team's success or failures, gaps?
In this moment, I want to first acknowledge that it took still commitment from my organization, which is a government organization, to have, a woman that looks like me with the title health equity still in my title and the name of our division, right? We have not just an attack on language and jargon, but also the work behind that. And so we're also in California. I'm also running California, I'm part of California's Obamacare marketplace. It's like target on target on target. And so I do think the commitment to the language is really important. And that's never been enough for Covered California. I mean, since our inception, the idea is that we are closing gaps, reducing disparities, and making it an equitable system for all Californians. And so that's from everything from how our marketing thinks about in language, in community, built by, for and by community advertising, to our benefit design, making it as easy to access in every language that folks need for every community, to making sure that we have both tech enablement, but also we have 16,000 enroller partners and agents across the state who live 15 minutes from most Californians, because we know not everybody wants to use tech, right? That's just actually 50% of our enrollments are still human touch. That's how people prefer to get, their enrollment for Covered California. In terms of accountability, there's a couple things. One is we don't just collect data for the sake of collecting data, but our demographic data is robust. We have a self-reported race and ethnicity completion rate of over 80%, and that has been true since 2014. So we have one of the most robust sets of demographic data layered on income, geography, et cetera. And we use that in an intersectional way. And then we release that, not in an aggregated, protected way, but we release it so we are accountable to Californians to see what are we doing about it. Right now, you could go onto our website and see what is the breast cancer screening rate for Black women in the Central Valley. Like that's the level of specificity of our data that's available. So that's one, is like data transparency and using the data meaningfully. And then I think I just want to be honest, equity work is hard and it's not one playbook. It's not just one thing all the time. Right now, as an example, we're seeing the highest declinations in childhood vaccines. The rates are dropping the most for white rural kids. I don't know how to solve for that. That's not my community. I don't know. And so, what does it look like to go into that community? Who should be going into that community to co-create, to co-develop, and figure it out? So, we track the data, we measure ourselves, account it, and we also, I think, are the first in the nation to hold our health plans accountable for reducing disparities and not white versus Black, because sometimes it's not the white population that's the highest performing population, but against a benchmark that we think is the benchmark we should all be pushing towards.
I love every bit of this. And I appreciate, as we're talking about equity, that you're naming accountability as a measure. And I don't think enough people actually intentionally put in accountability as a measure, right? So thank you for naming that and giving us some insight on how you manage that and what you consider while you're navigating that. And so we're going to move to a different question. For providers, technologists, and health leaders watching, what's the access question they should be asking before they build, buy, or ship anything?
Well, I know we have a lot of innovators on right now, and I don't want to throw a wet blanket on anybody's, great idea. But this is a very interesting moment in the health policy space, particularly around coverage. I'll just give you some of the stats in California. When the Affordable Care Act passed, California had about over a 17% uninsured rate, worse for communities of color. Upwards of 20% of some of our populations were uninsured. And we know, clear data on this, that if you are uninsured, you're more likely to delay care, to crash into the emergency room with worse outcomes, et cetera. So I don't think we could probably debate this part, but most people don't think being uninsured or without any type of coverage is the right path. Over the last decade plus, we've gotten to under 6% uninsured rate. So still more to go, but an incredible expansion in coverage and with the greatest gains for Black and Brown communities in terms of the uninsured rate. This current moment and the federal administration and the health policies are reversing a number of those pieces. Covered California alone is estimated to have 400,000 folks go without coverage because of a number of different policy changes and budgetary changes that are happening. On the Medi-Cal side, our Medicaid agency, a very conservative number is 2 million folks going uninsured. 2 million folks in California, and compounded by other states and of course other changes. That is a huge number of folks who were covered, who had care, who were accessing services, maybe in the middle of things like chemotherapy, who lose coverage. If we are not building solutions that account for that reality, we're not solving for the biggest pain point right now. So that's really the question is, are you building for today's reality or tomorrow's reality? What does access look like in the face of millions of folks losing coverage under a rapid time period? Nothing shiny is going to solve that I have heard to date. So that's my challenge, I think, to the innovators on the call.
I keep saying this, but this is so good. I think we can take each response to every question and have a breakout session, another fire chat. Seriously, I'm like, these are gems, and especially in the clinical space, the science research space, we don't hear enough about access, integration, centered in community, justice, equity, all of those pieces in a way where it's tangible. We can take actionable steps. We can integrate this into our back office and our operations in our output, right? So every piece that you're naming is so beautifully not just worded, but I think that it allows our audience to like take things away and put action behind it. I love also that you were mentioning about what are we creating for the future. Which leads me to, I guess our central question here is, where do you think we will be on access in 5 years? And I know that can look different, right? So under the worst case scenario, best case scenario, what are your thoughts?
I think the worst case scenario is that we have a proliferation of point solutions, things that are great, remote patient monitoring, AI-enabled agent primary care, whatever. And only a segment of the population that can access that. And also, even those that can access that, it is divorced from the sort of core chassis of their healthcare delivery. That to me is the worst case scenario, both that we are creating a more disparate system, and even those at the top tier of that are not getting the full realization of what they should be receiving from all of the innovation and technology advancements that we're seeing right now. I am also worried in that same worst case scenario that we may not be doing enough rigorous evaluation to be able to say, you know what, that actually didn't work. And like, let's just close that chapter and move to something else. So a little bit of like toxic positivity and optimism that's not being interrogated. I think in the best case scenario, the innovation technology advances is applied appropriately to our biggest pain points, which are known. We actually know. I've given you one: loss of coverage for millions of people across the United States. The people that we serve saying over and over and over again, affordability is the biggest issue for me. My wages I'm losing 25% of my wages from my premium and through my employer. I'm spending, I'm going into medical debt to try to just get basic care that I need. I'm stretching my medications. So I think that those are the pain points. In the best case, we have an integrated technology and tools, multiple front doors, essentially multiple access points, leading to some team/person with whom you have a long-standing trusted relationship. That to me is the destination that I would like to see us get to, and that is distributed in an equitable way, centering our most vulnerable.
That's so wonderful. I would like to wrap us up with your thoughts on something, and then we have time for like 2 questions from the chat. So, what is a moment in your work that reminded you exactly why this all matters, everything that you talked about today?
So I still see patients, and I practiced before the passage of the Affordable Care Act. And there's so many patients I think about on a daily basis, but there's one gentleman I'll never forget. And it was a gentleman who he was actually pretty young. He's probably like 50, but looked 75. And he had been living chronically unhoused for a number of years. So really like that weathering from street life. And he came in with advanced metastatic cancer. I think it might have been lung. And it was at a point in time where like actually the innovations in lung cancer treatment were happening really fast. So like in theory, we could have treated him. It would have been a really difficult course. He would have had to have both surgery and chemo and maybe some radiation. He's street dwelling. And I had all this conversation with him about all the choices in front of him and what might he want to do. And this gentleman chose to not even get a biopsy to confirm the type of lung cancer it was, but to transition straight to residential hospice, because that was literally the only way he could get housing. He chose an accelerated path to death because of a social driver. And to me, it's this perfect example of the intersection of coverage, access, and social drivers that we haven't yet to solve for, and frankly, is getting worse in this moment. So this is why I do the work every day and why I'm proud to be a public servant in this space.
Yeah. Thank you for giving that very real example of what people are navigating that we oftentimes don't get insight into. And I think everything you mentioned here, we can dive deeper into a longer conversation about the realities of all of this, right? So thank you for all of that. And I've been reading the chats, and folks are like, you should run for office. Like so that that poked out. I'm like, yes, I'm gonna send that to you. So you can just put it on a post-it in your office and just be mindful of that, because this is what the people want. Um, so we have time for one question. I know there's a few, but we have time for one question. And then I just encourage folks to connect with you where they can. So y'all can just deepen our community, deepen relationships, and dive deeper, ultimately on a plan forward. But our one and only question for you is, so you mentioned the problem with segregated care, but sometimes niche products are created because of a specific need and an ability from the team to serve that specific need. When it comes to digital care, what is the balance between build what you know versus build an integrated healthcare solution?
Yeah.
That's hard.
I think even where there's very niche specialized knowledge, one of the questions I would challenge folks to answer from inception is, how does this get back to other people who care about this topic for that person? Right? Is that the partner? Is that the kids? Is that the caregiver? Is it the primary care doctor? Is it the other specialist that's also thinking about that? I think that's the thing, is it is centering the person and the people who love them and are working for them as well. So, I mean, it could be as simple and low tech as, yes, we know that we have a summary that gets pushed forward on a regular basis to the other care team members, right? That's an example. It's not the best form of integration, but it is a type of coordination. And so that's what I would really challenge. So many times it's not even thought about, and you're talking about your value prop in isolation when actually what you're adding value could be redundant to something else over here if you're not at least attempting to assess the broader ecosystem.
Wonderful. Thank you so much, Dr. Soni. Thank you everyone for being a part of this conversation. I think it was so fruitful, and I can't wait to see the work that we do collectively together after this space. So I encourage you all to connect with Dr. Soni off the platform. I see some links to LinkedIn, so I'm pretty sure she will look at all of that and follow up at some point. So thank you again, and have a wonderful rest of the conference.
Thank you.
Bye, y'all.
All right. So, what a fantastic day. Thank you all so much. Before you go, I want to talk to you there for a second. We have now nominated Dr. Soni to run for office. We've had some fantastic conversations today. I want to share with you a little bit about why we are here. As we kind of wrap up today, for those of you guys who are still here, I want you to look at who's in the room. Earlier, I asked, who are you? We've got physicians, nurses, health founders, health tech operators, right? People building and delivering care for communities that really need it most. And for folks that generally look like us, this is not an accident. This is the world in the room that we were planning to create when we built HealthStack a couple of years ago. So, what you felt today, the excitement of the conversations, the caliber of the conversations, the honesty, the data, this is what we're going to continue to build as we move into the rest of this year. HealthStack Conference, I know that Morgan mentioned this at the top of the call, is coming up in November. In Houston, and we want you guys to stay involved. It sounds like you guys are like, more of this, more conversations like this. We are planning it. So, as you may know, Afrotech Conference, the sister brand to HealthStack, is celebrating 10 years in November in Houston. And for the last 3 years, we've done like a med tech track. We've kind of dabbled here. We are officially adding a 2-day HealthStack conference. And with your HealthStack ticket, you not just get access to sessions, but you also get CME credits. Okay. And we want you to join us for those conversations. We have the brightest and most innovative leaders, very similar to the speakers we've had today. And there's more before you go. This is very time sensitive for the hundreds of you guys still on the call today. If you buy your HealthStack ticket by the end of Monday, that is about 48 business hours from now, you will automatically get upgraded to an Afrotech All Access ticket, which means you get HealthStack, you get the brunches, lunches, receptions, dinners. You also get full access to the Afrotech conference week, as well as the HealthStack programming. There's no upcharge. The only difference is you got to move by Monday. We want to make sure that we are letting you all know that we value you being part of this conversation. We value being part of this community, and we want you in the room. That offer will also go out via email so you guys can reference it. But please go ahead and get your tickets. The room will fill up. And, for those of you all who have to get CME credits anyway, come do it with us. It also gives you access to a year-round community of healthcare leaders. So we want to make sure you have a seat in the room. Make sure you get your ticket. We're very excited to see you. And I appreciate you spending your morning or afternoon with us. We'll see you in Houston. Thanks, everybody.